Hello everyone, I'm Dr. Priyadarshini, and in this current presentation we're going to discuss about elevated urea and creatinine biochemical consequences. This topic is very important because these two parameters are routinely used to assess kidney function in clinical practice. Urea and creatinine are the most commonly used markers for renal function. Urea, the end product of protein metabolism produced in the liver via the urea cycle, excreted by kidneys. Creatinine is the breakdown product of creatine phosphate in muscles, produced at a relatively constant rate, filtered by kidneys. Mechanism of elevation. When both urea and creatinine are elevated, the condition is known as azotemia. Azotemia is defined as the accumulation of nitrogenous waste products in the blood. This occurs due to decreased glomerular filtration rate, decreased renal blood flow, obstruction to urine outflow. If not treated, azotemia can progress to uremia, which is a clinical syndrome with systemic symptoms. The causes of elevated urea and creatinine are divided into three major categories. Prerenal causes are hypovolemia, shock, heart failure. Intrinsic renal causes are AKI, CKD, glomerulonephritis, acute tubular necrosis. Postrenal causes occur due to obstruction, urinary tract obstruction, prostate enlargement, renal or ureteric stones. Biochemical basis of accumulation. Urea accumulation. Decreased filtration of urea, increased reabsorption of urea in proximal tubule leads to hyperuremia. Causes cellular osmotic changes, protein carbamylation, and enzyme dysfunction. Creatinine accumulation reflects decreased GFR directly, leads to accumulation of gonadino compounds, impaired cellular energy metabolism. Renal failure effects on acid-base balance. One of the most important biochemical consequences is metabolic acidosis. Acute and chronic renal failure are recognized cause of metabolic acidosis. When kidneys fail, they cannot excrete hydrogen ions, cannot regenerate bicarbonate. This leads to high anion gap metabolic acidosis. In renal tubular disorders, we can see normal anion gap metabolic acidosis, especially in renal tubular acidosis. If acidosis becomes severe and refractory, dialysis becomes urgent indication. Electrolyte imbalances. Renal failure also causes major electrolyte disturbances. Hyperkalemia occurs due to reduced potassium excretion and can be life-threatening, causing fatal arrhythmias. This is one of the indications for dialysis. Hyperphosphatemia is common in renal failure. Reduced renal production of 1,25-dihydroxyvitamin D in CKD causes hypocalcemia. This imbalance is managed by treating hyperphosphatemia first using oral phosphate binders. Hypermagnesemia occurs in chronic renal failure due to impaired magnesium excretion. Water and sodium balance. Retained uremic toxins during recovery can cause osmotic diuresis, causing hypernatremia. Severely reduced GFR leads to fluid overload associated with elevated BNP levels. Uremic toxin effects. Effect on the renal blood cells. Reduced kidney function, decreased erythropoietin. Consequences: normocytic normochromic anemia, reduced RBC lifespan, fatigue and weakness. Neurological biochemical changes. Uremia leads to increased blood-brain barrier permeability, neurotransmitter imbalance, accumulation of gonadinoneurotoxins. Clinically, confusion, peripheral neuropathy, seizures may be seen. Cardiovascular biochemical effects. Increase renin-angiotensin-aldosterone system, volume overload, hypertension, uremic pericarditis, accelerated atherosclerosis. Drug dosing and toxicity in renal failure. Effect on drug dosing. Kidney function plays a major role in drug excretion. Renal function determines clearance and dosing of many medications. Creatinine clearance less than 30 ml per minute requires dose adjustment for drugs such as low molecular weight heparin. Risk of drug toxicity. Renal failure increases the risk of drug accumulation and toxicity. Milrinone, use with caution due to the risk of arrhythmias and hypotension. Zoledronic acid should be avoided in significant renal failure. Indication for renal replacement therapy. When renal failure becomes severe, renal replacement therapy or dialysis is required. Acute kidney injury is a major indication for renal replacement therapy. Bun level is commonly used to monitor clearance of uremic toxins during dialysis and to assess the adequacy of treatment. To conclude, elevated urea and creatinine are the key indicators of kidney dysfunction. They lead to serious biochemical consequences such as metabolic acidosis, electrolyte imbalance, drug toxicity, and the need for renal replacement therapy. Early detection and intervention can prevent life-threatening complications. Thank you.